Hello, my name is Jeff Rochon and I'm the CEO of the Washington State Pharmacy Association. This program is entitled Pharmacists as Medical Providers, Recognition by Health Plans. It details a multi-year journey to successfully achieve provider status in Washington State, with a particular focus on pharmacists being recognized as providers by health plans, which allows them to bill for the services they provide to their patients. I have no financial relationships to disclose. I am fully employed with the Washington State Pharmacy Association. Some of our work to get pharmacists recognized by insurance carriers in Washington State was supported by grants from the Community Pharmacy Foundation. I would personally like to thank them for their support and patience while we underwent this multiple-year process. Here's what we're going to cover. First, we'll discuss how we open the door by explaining Washington State efforts on health insurance coverage for pharmacist-provided services. Then, we'll detail the subsequent implementation efforts we've uncovered, including enrollment processes for provider networks, the differences between pharmacy claims and medical claims, the technology gaps and potential solutions that have presented themselves, and how to bill a medical claim. Achieving provider status has been a goal for our profession for decades. And over the course of a number of years, it's become increasingly evident to us that the term provider status doesn't mean a whole lot to anyone outside of the pharmacy profession. What does resonate is patient access. But no matter what you call it, it has three core components: provider designation, optimization of the Pharmacy Practice Act, and payment for service. Where those three components converge is where we will achieve patient access to pharmacist-provided patient care. While medication reimbursement battles persist, it's very interesting to watch the provider status wave cresting. Throughout the country, state-level legislative efforts have been successful. At the federal level, provider status bill has achieved bicameral and bipartisan support and is positioned for success in the near future with a strong amount of advocacy backing its movement. But what we have seen throughout this movement across the country and at the federal level is that there are different approaches to achieve our common end. We're going to talk about one of those today. Malcolm Gladwell said it best in The Tipping Point, how little things can make a big difference, when he said, "The tipping point is that magic moment when an idea, trend, or social behavior crosses a threshold, tips, and spreads like wildfire." I truly believe that our profession is in the midst of a tipping point where hard work, opportunity, and expertise converge. We simply need to be ready to adapt and make the necessary changes to fully utilize our training. Let's talk a little bit about what's happening in the Pacific Northwest. Our first order of business into achieving patient access was to review those three core elements and really look and see what we needed to do to achieve patient access to pharmacists provided patient care services. We looked at the provider designation component, and over a number of years and multiple efforts, we've been able to review statutes and rules and make the necessary changes to have pharmacists incorporated into the appropriate practitioner and healthcare provider definitions. Next, we reviewed our Practice Act. RCW 1864.011 defines the pharmacy practice in Washington State to include the interpreting of prescription drug orders, the compounding, dispensing, labeling, and distribution of drugs and devices, but it also includes initiating and modifying drug therapy through written protocols and guidelines, administering of drugs and devices, and monitoring of drug therapy and use, which in rule is expanded to include the collecting and reviewing of patient drug use histories, measuring and reviewing routine patient vital signs, and ordering and evaluating the results of laboratory tests resulting to drug therapy. This Practice Act was actually written way back in 1979 by some forward-thinking pharmacy leaders And over the course of a number of decades, it has withstood the test of time, allowing pharmacists to integrate into practice settings and work within healthcare teams, as well as to expand services out into the community. Uh, while it does not include the independent prescriptive authority or statewide protocols that many states have come to find success with in recent years, we do believe that these collaborative relationships have allowed us to earn the trust of providers in our state and were a key component within the recent developments and advancements that we've had in the state of Washington. This Practice Act has allowed pharmacists in Washington State to go into a number of collaborative practice agreements with independent prescribers, namely in the areas of public health and chronic disease. This list in front of you is not comprehensive, and it actually mirrors many of the efforts throughout the country. In the 1990s, we started in immunizations to address adult immunization rates, and then we worked with the emergency contraception provision to address a problem with unintended pregnancies, and that expanded into areas like tobacco cessation in the late 1990s and emergency preparedness. Now we're in the opioid overdose and naloxone arena, much like a number of states are doing, contraception, and even HIV pre-exposure prophylaxis. In the chronic disease space, mostly done in ambulatory clinics, we've been expanding pharmacist utilization in anticoagulation, diabetes, hypertension, and now a lot more in the areas of pain. These collaborative practice agreements are on file with our Pharmacy Quality Assurance Commission, and there are more than 10,000 active collaborative practice agreements. To put that number into perspective, we have about 7,500 licensed pharmacists practicing in our state. So the integration of pharmacists into these care provision models has been successful. Despite the legal victories and the progress we made in provider designation and in scope of practice, we still didn't have all of our work accomplished. We weren't recognized as providers by the insurers. We, as many pharmacists throughout the country, have been limited in the ways we can bill for services to pharmacy contracts with PBMs for the professional services that are incorporated into those contracts. In the health systems, when we billed the medical benefit, we were limited to incident to billing at the lowest level and or facility only billing. In some cases, we may have been able to bill a little bit higher for workarounds, but for the most part, it was limited to either incident to or some specifically identified pharmacy provided service like vaccine administration or medication therapy management that had a workaround code. So after we reviewed all three core components, it became clear to us that we had work to do on one specific area, and that's payment for service. The issues we've had in the past, looking back at previous attempts, really were a focal point. Despite the fact that we had demonstrated an extensive integration into healthcare teams and ambulatory practice settings and nursing homes, we still had this glass ceiling that prevented the full utilization of pharmacists within all practice settings, and that's what we wanted to try to tackle. We realized that in order to offset pharmacists' time, there had to be a sustainable billable revenue stream to provide this care. It couldn't always be tied to either incident to billing or facility only billing and still be able to justify a pharmacist's FTE within these settings. We realized that in some settings, because a pharmacist couldn't bill for those, that other healthcare providers were being utilized even though they weren't the ones with the appropriate skill set to manage that patient, simply because the other healthcare provider could bill the medical benefit for the care at a higher level than a pharmacist could. So we really focused our efforts in that area. We also looked back at our previous efforts in the areas of trying to get certain services covered by insurance companies, but we realized that if we continue to tie our services to the pharmacy benefit and the relationship with the PBM, that would also be a rate limiting effort, because any payment for services out of the pharmacy benefit would drive up the pharmacy benefit, and therefore we would have to offset that with removal of medications and or less expensive medications, and that's kind of the issue that we kept bumping our head into over the past few years. We realized that we need to get outside of that pharmacy benefit and into the medical benefit and have pharmacists be recognized like a nurse practitioner, like a physician assistant, like a physician for the services they provide and get paid through a different mechanism. So our journey left us at the door to the provider kingdom. How do we become medical providers? How do we open that door? It's one that we needed to take some time and do some research to really figure out, and that's where our story begins. So the problem was pretty clear. We need to get into those medical provider networks. But how do we fix that problem? We identified stakeholders, partners, and champions and went through the process. We asked them to help us to propose solutions, and then we identified barriers to those solutions and worked to address those barriers. The stakeholders and champions were the usual suspects. We certainly looked at our members and the leadership in the pharmacies, hospitals, clinics, and long-term care facilities. We had to look to our legislature, who are our leaders and pharmacy champions within the legislature. We had to make sure we had the right individuals in this discussion from the agency leadership, because they can be very persuasive in legislative efforts as well as implementation efforts. Our incredible colleagues and friends at the universities were necessary to identify solutions here. We looked at provider organizations as well as different payers and consultants. The business decision makers, largely in human resources that make insurance decisions, as well as our ties with the patient advocacy groups throughout our state. So through this discovery, we identified a potential solution. It was in the form of an every category provider law buried within our insurance law. RCW, or our statute 4843045, requires health plans to include access to every type or every category of licensed medical provider, which through our provider designation work, we had identified pharmacists as licensed medical providers, and so we felt that we should be included in this law. Our rule, or WAC 24843-205, went on to state that health carriers shall not exclude any category of provider who provide healthcare services or care within their scope of practice. So we have it. This is our solution. This is all we needed. We identified it, and we needed to just make sure that this particular law was enforced to include pharmacists. But that would have been too easy. So we were faced with our first obstacle, and that was that initially this law was not enforced by the Insurance Commissioner's Office because it was interpreted to not include pharmacists. We worked with the Insurance Commissioner's Office over multiple years, so this slide actually represents several years of work as we tried to educate and request enforcement of this law to include pharmacists. However, it was to no avail. We have to recognize the volunteer efforts of Don Downing, who was a member of my board and also a former employee of the Washington State Pharmacy Association, but he is a professor at the University of Washington School of Pharmacy, and he dedicated several years of his life towards this effort, and in general was a huge part in finding this solution. We worked closely with legislators and the like, and it was through a conversation between Don Downing and Senator Linda Evans Parlett where a decision or a suggestion to get a AG opinion on whether or not pharmacists were included in this law was first identified. That led to Senator Parlett working with her colleagues on the Washington State Joint Select Committee for Healthcare Reform Implementation, essentially the healthcare committees in both the House and Senate, to request an Attorney General opinion in November 2012. In January of 2013, Attorney General Bob Ferguson's office responded with a 3-page document that is summarized here at the bottom of the slide, with a statement that pharmacists are healthcare providers and must be compensated for services included in the basic health plan that are within the scope of a pharmacist's practice. This informal opinion was not a silver bullet, but it did reinforce our long-held belief that payers should credential contract with pharmacists for the services we provide. When we got this informal opinion, we immediately brought it to the insurance commissioner's office. When the insurance commissioner's office received this informal opinion, they immediately took action and started to try to enforce the every category provider law to include pharmacists, and asked the health plans to include pharmacists in their networks. And what the health plans came back with was an interpretation that because they have contracts with PBMs, and those PBMs are contracted with pharmacies that pay for product and a professional service fee or a dispensing fee, that they do have pharmacists in their networks. The insurance commissioner's office immediately pushed back and said, that's not what the intent of this law is, but the plans had a very strong legal defense, and essentially what was identified was a legal loophole. And so we're faced with our second obstacle, addressing that legal loophole. And because the insurance commissioner's office was now well aware of the efforts of the health plans to try to exclude pharmacists, they were very helpful in identifying a legislative fix for the loophole that was presented to them, and that came in the form of Senate Bill 5557. So fast forward through some legislative work, and we were able to get a bill passed in gross substitute, Senate Bill 5557, that was passed and signed by the governor in 2015. Senator Linda Evans Parlett, the pharmacist in our state that was a champion on getting the AG informal opinion, also was the sponsor of the bill and was very much a part of its success. We thank her so much for her work and leadership to make sure that this was well received by her colleagues and understood, and we were successful. Our keys to passage for this piece of legislation were, of course, that Attorney General informal opinion, but also the fact that we had a case that was based off of an insurance code providing patient equity or patient access to all types of providers, and not simply including pharmacists in a already full network. The other component was that we did not try to expand scope of practice with this bill. We just focused on getting the clarification of that law to include pharmacists as healthcare providers that needed to be in the networks. And that helped to streamline it, because expansion of scope, turf issues in the legislature can be pretty nasty, and we were able to avoid that. We were also able to garner the support of the Hospital Association and eventually the Medical Association on this effort. The Hospital Association was supportive from the beginning, as they were well aware of the pharmacists within their system, that they could not bill equally for their time as they did with other healthcare providers, and they were faced with tough decisions on whether they were going to replace their clinical FTEs with other healthcare providers that they could bill for, even though they couldn't get the same level of expertise out of those for the services they were looking to provide to patients. The Medical Association was, because of our longstanding relationship with them, were not going to oppose our bill. They never stated that they would. We had convinced them that this would be beneficial and collaborative. However, they did not initially support it, and we asked them if they would come out in support of it. They said, well, we need to know that our members want it. So the relationships that our pharmacists had, primarily in clinic settings where they're working arm in arm with other physicians, became very beneficial. What we did was we asked those pharmacists in those settings to get letters of support for our legislation from their medical directors and the colleagues that they worked with, and they were able to get a number of those letters in a quick amount of time, and we presented those to the Medical Association, and they changed their stance and supported our bill. We also worked closely with agency leadership, the Insurance Commissioner's Office, because of all of our past work with them to identify this problem. We're very supportive of it, and the Department of Health had worked long long and hard with us to increase the use of pharmacists in various situations, so they understood the value. And despite the fact that we had eliminated the requirement that Medicaid fee-for-service be included in our bill, they did make sure that the fiscal note was appropriately written to not be additive services, but to be services that would have been provided by anybody else, therefore limiting the fiscal impact of the bill. And lastly, we worked with the payers and provider organizations that serve also as payers to address any concerns. And while they weren't in support of our bill, they did not oppose it on record. They simply stated that there would be a lot of work to do and that they needed more time to make it happen, but they did state on record that they felt pharmacists would be valuable additions to their networks. And so we were successful in getting this bill passed because of ongoing relationships and a lot of communication with opposition and valuable stakeholders. So let's look at the highlights real quickly. This bill is pretty simple. Quite honestly, it just clarified that pharmacists are supposed to be included in this every category provider law. So it stated that health plans must recognize pharmacists as patient care providers of covered medical benefits, that there must be an adequate number of pharmacists within their networks, that it's inclusive of the services within the scope of a pharmacist practice, and only covered services within those will be paid for. It did clarify specifically to address the loophole that pharmacies in health plans drug benefit networks do not satisfy these new requirements. And it required the commercial plans that are under the purview of the Insurance Commissioner's Office, which are large group, small group, individual, and family plans, to comply with this law. Our path to provider status started in May of 2015, actually much before that as we were trying to figure this out, but officially the legislation was passed then. And then we had a advisory committee to look at implementation best practices that started meeting in summer of 2015. Those deliverables from that committee were delivered at the end of 2015 to the Insurance Commissioner's Office, and then implementation began in January of 2016 for health plans that had pharmacists with delegated credentialing agreements within their institutions, and in January 1 of 2017 it opened up to all pharmacists in all practice settings. So the tiered implementation was an interesting situation. The health plan said they didn't actually publicly come out against the legislation. What they did say was this was going to be a lot of work to do, but they testified to the value of pharmacists within the provider networks. So their ask was to push the implementation to 2017. And we did not want that to happen because that was a long ways away. We were in early months of 2015 at the time, and stated, you know what? Those health plans that already have like an internal credentialing process with hospitals and clinics, they don't have as much work to do to include pharmacists that work in those settings into a system that already exists. And so we were able to get a 2016 rollout for those pharmacists that work within those systems that had an internal credentialing and contracting system that already existed. In 2017, all the other pharmacists would be involved because that was the bulk of the work that needed to be done to create a new system for those folks. So the advisory committee process was actually really important, and one that I thought might be a barrier to implementation and delay in implementation, but it turned out that it was a very necessary component. By the law, the Insurance Commissioner's Office designated a lead organization. One Health Port was that organization, and they formed this advisory committee. And the task of the committee was to develop best practice recommendations for standards on credentialing and privileging of pharmacists, billing and payment for their services. The committee was composed of a Noah's Ark of representation. We really had two of everything. Or more. We had the lead organization facilitator who was instrumental in making sure we had all different views represented. The state agencies were represented, Department of Health and Healthcare Authority, and who does our Medicaid and public employees, as well as the Insurance Commissioner's Office. Provider associations like the Medical Association, Hospital Association, and of course the Pharmacy Association were engaged. The carriers were engaged, and the Blues were heavily involved in this, as well as a number of other carriers, including some national carrier representation. We had representatives from healthcare systems that coordinate coverage and care, the payer and provider combo, which are the HMOs, ACOs, and MCOs, as well as hospitals that had these internal credentialing processes and pharmacists within those, or clinics and other health facilities that have pharmacists providing medical services already within their midst, and then the pharmacy schools. The intent of this advisory committee work was to ensure that pharmacists were treated as just like every other healthcare provider. That was our goal through this. We didn't want any workarounds. We wanted them to just, equality was our main mantra. Good, bad, or indifferent, don't treat us any differently, because if we can integrate into the system that already exists, and we have a very dynamic, shifting healthcare system with reimbursement models that are pushing away from fee-for-service and going into bundled payments, we wanted to make sure that we were so entrenched in the way everybody else does it that they couldn't carve us out in future state. And so our goal was to make sure that there was equality throughout. And the intent of this really reinforce that we would be treated just like any other provider within the health plan's mind. And that was in the areas of billing, processing of those claims, and then the payment of those claims for medical services. Specific deliverables that came out of this were a frequently asked questions document that identified key definitions and key questions, as well as specific health plan policy directives and pharmacists and other provider expectations. The frequently asked questions document turned out to be a very valuable document. It included key definitions and key questions that paved the way for our ongoing work. It allowed a number of different stakeholders to learn about key areas like what a scope of pharmacist practice is and what we are trained to do. It also allowed the providers to better understand credentialing and privileging and the roles of the health plan and provider groups within those processes. And in addition, we actually asked them to include a definition for collaborative drug therapy agreements, because it became obvious to us that the plans were considering using collaborative drug therapy agreements as a mechanism or requirement to become a part of their networks. And so in our efforts to make sure that we are treated equally with other healthcare providers, we posed the question to the health plans: do you in fact pay any healthcare provider simply to prescribe a medication? And their answer was a resounding no. And so we were able to explain to them that these collaborative drug therapy agreements essentially are prescriptive authority agreements, and that they do not increase or deal with the services provided, and that in fact many of the services that are covered services are encompassed within our scope of practice, and that should not be a requirement to be in the networks. The key questions that were addressed, and this is just a few of them, as I had stated, this is a 13-page document, it's a larger document, but one of them was surrounding diagnosis codes, and it said if a diagnosis is required to bill for services and pharmacists can't diagnose, then how can we have the right code to bill for a service? And what was identified through much discussion was that a diagnosis by another prescriber that's been working collaboratively with a pharmacist could be utilized to bill for chronic disease state services, and that a newly identified need such as vaccine administration or contraception or tobacco cessation or naloxone or other things there's codes that can be utilized to document that a patient assessment has identified a new need for a service to be provided. They also wanted us to tell them specifically what billing codes what pharmacists would be billing, and we kept pushing back to anything within our scope of practice, that pharmacists were in fact working in a myriad of different settings, and that those codes would largely be in wellness and prevention and chronic disease states, but they could be in acute care and other areas. And so we held to categories of care to make sure that we weren't limiting our potential billing moments, and that it was tied directly to scope of practice like other healthcare providers. And then lastly, there was a question about primary care provider designation or specialty care provider designation, and we had held to our presumption that we wanted to be primary care providers within their systems, and the health plans are the ones that designate whether you're primary care or specialty care. And upon much discussion, learned that the definition by health plans is that a primary care provider deals with a patient from birth certificate to death certificate, and that in fact most of their providers are specialty care providers, and that we would indeed fall in that category. I would highly recommend that these are utilized by any state who is considering this type of discussion with health plans, because these consensus documents were worked upon by health plans and providers in department agency leadership, and could be excellent resources moving forward. The Health Plan Policy Directives document outlined the requirements for health plans to abide by best practices that would allow for pharmacists to get into these networks. And so they touched on areas of contracting, credentialing, utilization management, and then the coding, billing, and reimbursement components. They could largely be summarized as following the same conditions and requirements as other healthcare providers, and it gets into the specifics. We've used this particular document to help health plans understand the law and what the advisory committee had determined as best practices to help guide them in their implementation efforts. Similarly, the provider expectations document outlined what the requirements and expectations for pharmacists would be in dealing with these health plans and getting into these provider networks. And they touch on largely the same areas as the health plan policy directives, but with specifics requirements for pharmacists. We've utilized this as we've tried to train pharmacists on what they need to expect and what they should expect when they work with the health plans. And after about 6 months of advisory committee work, we really took a big step forwards towards our end goal. And this work actually brought about 3 key components. One, it provided consensus documents that were agreed upon by a diverse representation of the healthcare community, and laid out best practice guidance, not law, but best practice guidance that's helped for the implementation by health plans and by pharmacists, and getting pharmacists into these networks. And then it provided a really good venue for large subsets of groups and opinions to clarify and address assumptions and misinterpretations from all the different vantage points that we could share throughout the community. So we were very happy with the time spent, and we believe these documents will be helpful not only in our state, but potentially throughout the country. So our key takeaways from our efforts to achieve provider status really focused on going back to those core components and identifying what you've accomplished and what you still need to hone in on. And in our particular case, we looked at payer recognition. And then it looked at how do we address the barriers. So in our case, we were able to highlight a patient choice law within the insurance code as a portal to get recognition. That we also identified that if you have an existing law but it's not being enforced, that you may be able to utilize a judicial branch, and an attorney general opinion could be helpful in getting a law enforced. The core tenets of patient-centered messaging and collaboration with stakeholders ring true, and they were essential. And at the end of the day, it was pretty hard for other stakeholders to refute that pharmacists should have equal treatment if we abide by the same rules and regulations. We finally shattered that glass ceiling that had held pharmacists down for so long. Health plans are now required to treat us like other healthcare providers, and commercial health plans must include pharmacists within their medical provider networks, which makes a pharmacist in Washington State eligible to bill medical claims that are within their scope of practice as long as they're covered under the medical benefit. No longer are pharmacists limited to workaround codes, incident to billing, facility only billing, and probably the biggest accomplishment is now this change has placed the focus on providers contracting with health plans and taking the emphasis off of PBMs contracting with pharmacies and having pharmacists included in those contracts. What that does is it changes the mechanism of payment from the pharmacy benefit to the medical benefit. The medical claims being paid out of the medical benefit is important for a number of reasons. One, the actual cost savings to the healthcare system and for the value of what pharmacists provide are realized in the medical benefit for the most part. Certainly in the pharmacy benefit, if we change a patient from a higher cost drug to a lower cost medication or recommend to take them off of medications, that can help the pharmacy budget. But if we're avoiding hospitalizations and emergency room visits and additional physician visits and better care for patients, those are actually realized in the medical benefit. And so this is a more transparent way to show the value of what pharmacists can do. And that is a cause for celebration. And we really needed to recognize the hard work that it took to get to where we're at, the victory in opening up that medical provider network door and getting into those provider networks, which will allow us to be recognized for the care we provide to patients as healthcare providers. This took a lot of work from a lot of people, and we wanted to celebrate and recognize their accomplishments. But we had to do so in a muted tone. We didn't want to shout from the rooftops just yet. What we needed to do was figure out how we were going to make this available to all patients, and so we knew, because of the tiered implementation dates, that this wouldn't be in front of patients for a couple of years, and we didn't want to jump the gun. So we recognized the important accomplishment and the people involved, and then we cleaned up after our celebration, and we looked at each other and said, now what? Where do we go from here? We passed the law. We got guidance from the advisory committee deliverables, including our frequently asked questions document with the key questions and definitions, and some consensus documents on implementation best practices. And ultimately, our goal of equal treatment was achieved. But we found some major gaps in our guidance. So we had to contain our excitement and really focus in on our new challenges. We had worked hard to achieve equality, but what that really meant was that we were going to be held to the same standards as other providers, and we needed to figure out what that meant. It really meant that we had a lot to learn. Billing and medical claims are very different from billing pharmacy claims, and we were given very little in the way of direction on business processes or workflow, coding and documentation, and then health information technology issues like clinical medical record management and billing systems. So we had to figure out what was our next plan of attack. We outlined our next steps by working with our members and partners to kind of put the pieces back together. We needed to find out what these new knowledge gaps were and ways to address them. And because of the way that medical provider networks work, we wanted to ensure that we understood them well enough to advocate for the appropriate integration of pharmacists into these networks. We knew that medical billing was different, and so we wanted to demystify this medical billing process and very specifically compare it to the pharmacy billing process and where the gaps and differences might lie. With this increased opportunity to provide care, we want to make sure that we could capture the value by collecting and sharing data supporting the value of these pharmacist provided services to more clearly demonstrate our value in the healthcare team. And lastly, but certainly not least, we didn't want our efforts to be in a bubble in the Pacific Northwest, and we wanted to make sure we had our eyes on how can we do this so that we can share it with our colleagues throughout the country and in some way potentially help them in their ongoing efforts towards provider status. We identified a few key knowledge gaps. First, how do we enroll in these networks? What are the processes for contracting and credentialing and privileging that other healthcare providers are held to? Secondly, we needed to get a better understanding of the medical benefit, what covered services are within our scope of practice. For so long, we have tried to get insurance companies to cover what we do, namely by trying to get coverage for medication therapy management. What we wanted to do was see what coverage services were already within that medical benefit and align them with what pharmacists do in our care provision, and make sure we're using the same terms as that were encompassed in the medical benefit. We've talked about the need to really understand medical billing processes, and so we really wanted to get a full understanding of all the moving parts within that and train our members to understand how to bill medical claims successfully. And then lastly, we knew that health information technology was going to need to be adjusted to submit these claims and to store the data and integrate into electronic medical records. And so we had to figure out what those gaps were and how to address them. This body of work led us to decide we needed to form some implementation work groups. So the association put together a contracting, credentialing, and privileging work group, a billing, coding, and documentation work group, a technology and communications work group, and an outcomes and research work group. The contracting, credentialing, and privileging work group was tasked with determining best practices and tools that helped pharmacists enroll in these provider networks and contract with health plans. Really needed to understand what the credentialing processes that other healthcare providers have to go through and what would be required for pharmacists, what contracts would be offered to these pharmacists, and how do we appropriately understand the limitations and or any negotiating that would be needed and necessary. And how does privileging tie into this equation? Is it vastly different from credentialing? And if so, how do pharmacists ensure that they have the appropriate privileges to provide care to the patients with the extent of their licensure and the credentials that they possess? The billing, coding, and documentation work group really was focused on making sure that pharmacists understood how to bill and the pharmacy technicians understood how to bill, so that these bills would be appropriately received by the health plans and therefore be eligible for reimbursement. There's new standards, new processes, tricks of the trade that has been learned over years by some expert billing specialists. And so what could we learn and share with our members that would make for billable, payable claims that reimburse pharmacists and make sure that they complied with all of the standards that are required in this new space. The technology and communications work group really need work to determine what is needed for a pharmacist to submit these medical claims and comply with industry standards so that we can integrate into the system as it currently exists and have the right partners to do that with. And then the outcomes and research work group, which is really, we think, one of the long enduring work groups out of all of these because it's outside of the implementation, really is going to be focusing on measuring and reporting quality metrics that show the value of pharmacists to provide care and highlighting and directing those efforts to really how the health plans are graded so that we can demonstrate to the health plans the value of having pharmacists in their networks. So when the dust settled, we basically ended up in this brave new world. Yes, provider status is completely deserved, and it makes our skills more relevant in this very dynamic healthcare landscape that we're in. But the more and more we discover, we realize that it definitely comes with new responsibilities, new obligations, and more accountability. It's an exciting time, and now we've got different safeguards and guidelines that we need to learn to make sure that we can live in this provider space. So in an effort to make it as simple as possible, we try to lay out a roadmap. And actually, this could be called a treasure map because there is money at the end. But it really, we could break it down into 4 parts. First, we have to get into those networks. We need to enroll and understand what it takes to do so. Secondly, we have to figure out what services we're going to provide to our patients and what the rules and specific codes are so that we can bill and document appropriately. Then we have to make sure we can actually submit those bills within our systems. So we have to look at the technology, fill those gaps, and make sure we can submit electronic claims to health plans, which is different from submitting a pharmacy claim to a PBM. And then once that is accomplished, we start submitting medical claims. And then we can increase the number of services we provide. So we're going to try to break this down into those 4 components to help with the understanding of the road ahead. So let's talk a little bit about how to enroll in these health plan provider networks. This section of the program is going to really be detailing much of the work done by our contracting, credentialing, and privileging work group as we try to understand how best to enroll in these provider networks and any tools that could make it easier for pharmacists to understand this new process. As we reviewed those enrollment processes that currently exist for all other healthcare providers, we realized that they're very similar. They can differ in their requirements on enrollment, but they have a lot of common elements, and in some ways they've been standardized. There are components of this process that can be delegated to specific staff members, and so that they can help become specialists in this arena. And in fact, in hospitals, their medical staffing offices are made up of these delegated staff members to become specialists in understanding how to get pharmacists and physicians and nurses and other healthcare providers into these networks and keep them eligible for patients to receive care that is covered by their insurance. And the one thing that really stood out to us was that nowhere that we can find are these commercial health plans prohibited from including pharmacists in their networks. They've chosen not to for some reason, and in Washington State we had a law that required them to. But if they see value, they could add pharmacists in other states to these health plans. And so our hope is that with some of the value-based metrics and reporting that we are trying to capture and provide, that it will make it more enticing for commercial health plans in other parts of the country to include pharmacists without the need to pass legislation. The first step in being recognized by health plans is figuring out which ones we need to contact. So we know we need to get into these networks to be eligible to bill for covered services, but which health plans cover our patients? There are commercial plans and large group, small group, individual, family, and self-insured, and then there are public plans like Medicaid fee-for-service, Medicaid managed care, and Medicare. And while in our state, not every one of these plans is recognizing pharmacists within their networks, it's important for us to know which of these plans cover our patients. And as we advocate for work to open up the door for Medicare and work with some of the public payers, we are going to be focusing on the commercial plan implementation in Washington State. And then once we know which of these groups cover our patients, we can start the enrollment process. How does this all work? As we started to look at the enrollment process, we realized that there were a number of new terms and processes that we needed to understand. So I'm going to take a few minutes and discuss some of those with you. First, a credential. A credential is essentially evidence. It's evidence of your professional qualifications. It could be in the form of your licensure or your academic degree, evidence that you've completed a residency or a fellowship or certain training certificates, board certifications, and even CE credit. But the credential, the evidence that is provided demonstrates that you have a certain professional qualification. Then What's a certificate? Well, certificates are oftentimes used in parallel to a credential, and actually it's with good reason because the certificate can be used as a credential. And so you can think of a certificate in different means by then putting it in the bucket of a credential that shows that you have completed a certain level of proficiency, and that's your evidence to show that you're good at whatever um, skill set you got from that certificate. There are some lists, and the Council on Credentialing in Pharmacy has developed a list. It's not an all-inclusive list because new certifications are always developed, but uh, it's a snapshot, and so you can look at some of those recognized certifications for pharmacists. There are many that are offered by national associations and by state associations, and those all would be inclusive of that. But there's still areas of practice where no certifications exist. So this is an evolving area, and with the need to credential and privilege in front of pharmacists, these might get a higher level of focus and be more valuable to the pharmacists as they now have a reason to get a certificate to increase the credentials they have in their tool belt. Credentialing is a process that essentially documents and demonstrates that a healthcare professional has attained the appropriate amount of credentials and qualifications to provide their level of care, their scope of care for the services they provide in a particular setting. It's a way to document and review all those credentials for each individual. The idea of credentialing is really based on a few core principles. Well, first and foremost, it's required for enrollment in health plans. So now there's a whole new reason why pharmacists would want to start gaining credentials and being credentialed. But they're all basically quality assurance based. This is a way that pharmacists can demonstrate their qualifications and ultimately defend their patient care privileges. It really was born out of a patient and societal need to demonstrate that the healthcare providers within these networks or the healthcare providers that are providing care have a certain level of competency and they can demonstrate that. It's important as we dive into this new space that we look at paralleling all of our work with the similar processes that other healthcare providers utilize so that when we are evaluating ourselves within a healthcare team that we're held to the same standards, and so we have highly encouraged any credentialing processes to emulate that of other healthcare providers. And eventually this will grow into a profession-wide consensus, and that is important as demonstrated by the medical community, where the credentialing has gone off into different specialties. And while other healthcare providers don't have that same level of credentialing for their specialties, you can see that it may be important for health plans to start credentialing their specialist providers in their networks differently than they do all other healthcare providers. All right, so I mentioned the definition of credentialing, but it gets a little more complex. There's actually a couple different processes. One is the granting of a credential to an individual that has qualifications in a certain area. So that could be, an example of that could be that you've passed your tests and now you get your licensure in your state, or you've done the study and then you pass your board certification and now you can provide care and have that board certification. That's one credentialing process. The other credentialing process is when a health plan or an organization or an institution gathers credentials, verifies those, and assesses an individual's qualifications to provide those patient care services. And that's the process that we'll be referring to, because that's the one that health plans and your pharmacy or hospital or clinic or long-term care facility will be utilizing in healthcare. These can be very simple or they can be very complex. The simple process is based on licensure and academic achievement. And as they get more complex, as they have in the medical specialties, it could be more in the clinical experience and specialty practice beyond a normal professional licensure. You've got podiatrists and brain surgeons and others that have different credentialing processes because of their expertise. What we found in our discovery here is that most healthcare providers are held more towards a simple credentialing process, and medicine is the only one that really has a more complex at current time. Credentialing goes through a couple of different major pathways. One is direct credentialing, and two is a delegated credentialing. The direct credentialing basically, well, first off, it's the most common. It's when the healthcare provider reaches out to all the different health plans and goes through all their enrollment processes. And that happens with the vast majority of healthcare providers as they try to enroll and credential with health plans. A delegated credentialing is actually kind of a fast forward, if you will. It's probably a more efficient process, and typically it's faster. It alleviates some of the bottleneck that the direct credentialing does. But that's when a provider organization like a hospital or a clinic or even a pharmacy goes into an agreement with a health plan and says, hey, instead of all of my healthcare providers under my roof going through the direct credentialing route, I'm doing all that stuff internally. If I do it by your rules, can I fast forward through your direct credentialing process and ease some of the pain here? And what you see in our state, there's about 25 of these delegated credentialing agreements where the hospital or the clinic is doing internal credentialing, and then they submit a list of everybody who qualifies to the plan, and the plan checks it off. But there's a lot of quality assurance processes within that to ensure that the provider organization is following the rules, but it certainly can be faster and more efficient. The only barrier to that is that it will only apply to that provider when they're working in that provider organization. And so in cases where somebody might work in multiple organizations, they may need to do a direct credentialing route to make sure that their contracts apply to all the different settings that they're working at, or they might go through multiple delegated credentialing processes to cover the different areas which they're practicing. The credentialing process is kind of a secular event, and it really goes from an application process, which can be quite extensive, to then the verification of that information, all that evidence, to the analysis and review of that to make sure that it's right and meets the minimum threshold, and then a decision is made to notify the applicant, and then it starts over. There's an ongoing monitor and evaluation quality improvement process, and then there's a re-credentialing process that occurs. And so this is not new. This is just something we are now going to be held to. What I can say is that a lot of pharmacists are already going through a credentialing process, maybe not this defined or rigorous, but in order to practice and be employed, there is a credentialing that goes on. We may not call it that in a lot of settings, but it does exist. You have to make sure that you are licensed and the like. This is just going to have to make us refine our process and make it more transparent. The Council on Credentialing in Pharmacy that I referred to earlier was actually established in 1999 to take a look at this stuff, and there's actually wonderful resources available, and I think the work of this group is going to only grow in importance. It was a little ahead of its time in '99, but I think it's going to be a prominent vehicle for learning and sharing of information moving forward. Okay, so let's talk about what a privilege is. Privileges are granted by a healthcare institution, so a hospital, a clinic, a pharmacy, a nursing home. They're granted to a provider, and they give the authority to render a specific service. An example could be admitting privileges, where a physician is given the right to admit certain patients to a hospital. That certainly isn't the case for most pharmacists, but we will largely be in the clinical privileges component, and that gives a healthcare provider or pharmacist the right to provide treatment. So clinical privileges are both facility and individual specific. So say a pharmacy is deciding which of their healthcare providers are going to be able to provide vaccinations, and they have decided that the credential necessary is a certificate program that's based off of the CDC. And so they will identify the credentials, they'll do a privileging process, and they'll say that pharmacist A, B, and C, you have completed the training and you will have an immunization privilege, and the ones that had not will not be able to provide immunizations in that pharmacy. The process of privileging is taking those credentials that have been identified and provided to the healthcare organization and determining what skill sets or what credentials that particular healthcare provider has to provide what services under that within that organization or under the roof of that healthcare facility. The process is, as I stated before, organization dependent, but most of them include some sort of review of the credentials and performance of that provider, and then they establish that provider has demonstrated certain competency to provide said services. And they have to make sure that those services are within the scope of provision of that organization, and that the organization can support the delivery. So there's two sides to this. The provider side and the organization side. The organization side, they must be able to allow for that care and support that care to be provided within their scope of provision. So a sample process looks a little bit like this. You've got your initial privileges, so the application is requested, that's reviewed by a committee of the peers. That peer review component is absolutely necessary, and then there's an approval or maybe a modification, and then that happens as part of a CQI process consistently, maybe every year or so, where they will review over the designated period of time, make sure there are any liability issues, see any new information the provider can demonstrate on new credentials that they might need, and then they can establish new privileges at that time. The purpose of the privileging process is essentially based off of quality assurance, and it is a mechanism for those healthcare organizations to govern who provides what services and who does not. So it allows for a healthcare professional to demonstrate that they are competent and valued, and to be given the authority to provide the care within their said employer agency. When designing these things, again, we want to keep going back to making sure that they parallel existing processes. If you're working within a healthcare institution that has privileging processes for nurses and PAs and physicians, then we believe that we should align our efforts with those so that we can compare pharmacists with the other healthcare providers that are already being evaluated through these processes, so that it's not and completely unique and different. But there is a relationship to reimbursement for all this stuff. If you think about the public expectation of competence and getting into these networks, you have to have the credentials and get into the networks. You have to demonstrate your value in that. So if you don't get into those networks, you don't get reimbursed. And then if you take it one step further, the quality improvement expectations are ongoing, and the alignment with the value-based performance measures of HEDIS and the star ratings and PQRS all align with this quality assurance, reinforcing this quality assurance mechanism to make sure that we're in those networks and getting paid. And so we want to make sure that our evaluation aligns with the other providers, as we likely will be evaluated by the same means. Now that we've gone over the processes and the definitions, Which groups do what within credentialing and privileging? Health plans only credential pharmacists. They do not privilege them. This is important because in the eyes of a health plan, a pharmacist is a pharmacist is a pharmacist. What they will do is they establish the minimum credential criteria, and then they review and verify the information upon the application and decide if they want to contract with the pharmacist. But they do not treat pharmacists differently within their system. They do not treat other healthcare providers differently within their system, with the exception of specialist physicians who have developed additional, more complex credentialing requirements. But for the purposes of our knowledge and the implementation of pharmacists, a health plan will gather credentials, verify them, and they will not vary their requirements from pharmacist to pharmacist. They will treat all pharmacists the same. Provider organizations, such as hospitals, pharmacists, clinics, and nursing homes, credential and privilege their providers. They credential their providers internally for reasons of employment, and then they utilize those credentials to determine what privileges they're going to provide to allow their providers to do under their roof. Because they privilege, they are the ones that can determine if a pharmacist with certain credentials can do some things and pharmacists without certain credentials cannot do some things. So provider organizations can determine how to treat different pharmacists under their system differently, and that's not done by the health plans, only by the provider organizations. The role of the provider and health plan organizations, which are the ACOs, the MCOs, the HMOs, the groups that are not only provider groups but also health plans all in one roof, they have the ability to credential and privilege their providers, much like the provider organizations, because they are a provider organization. So they are not limited solely to credentialing. They can differentiate between pharmacists within their system based off of their credentials and allow them different privileges, and hold them certain pharmacists that want to do certain things to a higher standard. But that is not because of the health plan organization side of the equation, but because of the provider organization side. So how do you get into these networks? What's the enrollment process look like? It's primarily online. There are paper mechanisms, but it's primarily online, going to a health plan provider enrollment page. Now, if you go into these health plan provider enrollment pages and you go into the pharmacist section, you're going to get into the pharmacy side of the equation, which is the PBM contracts. You need to go into the provider side, and the provider enrollment mechanisms are consistent, primarily consistent for all healthcare providers in these provider networks. Some plans do require a phone call, but most of them have a web portal. And then the enrollment is inclusive of the completion of a application, whether it's a practitioner application or some sort of a form that for each of the plans. Some states, those are consistent applications, like there's a universal application, and some states the plans have different applications. But once you fill out that application, then you start this credentialing process, and after the credentialing process, ultimately it leads to the contracting process, which is as an individual with these health plans. There are requirements for getting into these networks, and there are a few things that you should just be able to check off right away. First off, every pharmacist will need to have their own NPI number. When we've been working in many pharmacies, the pharmacy contract with the PBM or the insurance carrier allowed us to use the pharmacy NPI number, but it's the entity who transmits the health information that needs to have an NPI number, and when the pharmacist is the contracted entity, they're going to have to use a pharmacist NPI number. So you do need to get an additional NPI number if you don't have an individual one. One of the things we learned along the way was that there are taxonomy codes attached to NPI numbers. And so for your individual NPI number, you will want to make sure that you are affiliating or designating the appropriate taxonomy code with your NPI number. The web page on this slide will point you to a list of the taxonomy codes, and there are a bunch of pharmacy codes there that are specific to different settings, critical care and long-term care, community, hospital, and even infusion services. And so you want to make sure that the appropriate and taxonomy code is attached to your NPI number. And another standard requirement is you need to contract, you need to have your own professional liability insurance. It can't be the employer's insurance. Now, a group of providers can get together and do professional liability insurance. There are emergency room doctor groups, the physician groups that pull together and get liability insurance and contract together. But you need to have something that's personal, that's not just your employer's. Each of these health plans have different thresholds that you need, so you should look at those thresholds when you contract with the plans and make sure that your professional liability insurance has the right threshold of coverage. And then you start your credentialing process. You fill out this form, but in order to know which ones you're going to do, you need to figure out which process applies to you. So are you going to have to go the direct route that most people do, or are you going to go a delegated or internal credentialing route because your practice setting offers that? The direct credentialing contracting route is very helpful if you take a look at your patient population and identify which health plans are the most heavily utilized so that you can try to enroll with those groups first. For the delegated credentialing route, you should be asking internal questions to find out what the process is in-house. Do you work through a medical staffing office or another group within the hospital or clinic or long-term care facility and go through an application process with them, and that could streamline your overall effort. Then you start the enrollment process, and that's the completion of the application and submission to the plan through their systems. In the delegated credentialing space, that might be as simple as just completing one form and providing it to the medical staff office, and they do the rest of the work. But in the direct credentialing process, that could be that you've got 15 different insurance companies you're reaching out to, and you might need to do that several times for those individual groups. And so it's important that you prioritize the plans that are most crucial to your patient population and get those going first. So let's talk a little bit about that practitioner application. It's essentially a robust document full of your credentials, not dissimilar to your CV, but embellished. It encompasses quite a bit of your practice setting information, all of the different trainings and education that you've done, and it allows for the health plan to understand everything about the provider you are and the practice settings that you work under. There's a number of different forms, and in the state of Washington, we actually have one standardized form called the Washington Practitioner Application, but some of the health plans may require specific applications. They largely encompass the same stuff, and that's why a standardized form has been utilized in Washington State. Your state professional license and a DA certificate if you have one, evidence that you have liability policy in place, and your CV, but they make special note to ensure that you don't utilize that solely as your application that is duly noted on our practitioner application. And then your individual NPI number and any Medicaid or LNI or Medicare numbers that you might have, or specialties or subspecialties. It goes further to find out information about your practice setting, and you can actually put in primary and secondary locations, whether or not you have a tax ID number or your primary care provider or a specialist, specifics of your practice setting, and then if you have any supervising responsibility or if your practice is accepting new patients and are you wheelchair accessible, and and provide different foreign languages. A number of different components are included within this application. And then it requires you to look at to insert information about your professional licensure, registrations and certificates, and undergrad and professional education, your internships, residencies, fellowships, and the like, board certification, even faculty and teaching appointments. It also asks you to list your hospital affiliation or any military affiliation and previous work history, peer references, professional affiliations, and then there's an area called attestations, which is basically a catch-all for other stuff. So they ask things like sanctions, criminal issues, litigation or malpractice, any ongoing issues, and any affirmation of your abilities. And that affirmation of your abilities actually is the area that we're putting in where our collaborative drug therapy agreements or collaborative practice agreements are for pharmacists, because that is what's above and beyond the standard scope of practice of a pharmacist that needs to be documented within these applications, but there was no real good place to put it because this is a general form for everybody else, and so it was agreed that that would be the area that would best serve to put our collaborative drug therapy agreement information. And then we wait. It can be expected that we'll wait. This process for reviewing the applications can take between 30 and 120 days is what we're told, and that the process is not as streamlined as one would hope. What we can expect as providers is that the plans should notify us that they are reviewing our completed contract, and then upon that completed review, they should notify us of approval. And in the case of the plans notifying, it may be done by either mailing or emailing a copy of the provider contract that would just need to be signed and returned. This is a frustrating sequence of events for all healthcare providers, and we were actually contacted immediately by the Washington State Medical Association for help and support in passage of legislation to provide consistent and streamlined timelines for appropriate responses from the health plans to ensure that this can be done in an expedited manner. These contracts that will be offered are on an individual basis. So we needed to get a little bit better understanding of what was included in them. And what we found out was that the health plans are, or at least are telling us that they have similar contracts from practitioner to practitioner. Not just pharmacist to pharmacist, but nurse practitioners, PAs, and physicians. What could differ is the rates and some allowances, but for the most part, the same terms and conditions are offered, and that it's a fairly simple contracting process. Because these are individual contracts, though, it does allow for pharmacists to negotiate different rates if they so choose. And that we feel, because there was no specific percentage tied to any piece of legislation, we feel that that offers them a competitive advantage, and also the power to say in areas where access is limited, that they have a greater value to that network and to that health plan, and that they can request higher rates. So we think that that offers appropriate negotiating capacities, and time will tell on how that plays out. Enrollment in health plans, credentialing, privileging, and contracting are new pharmacist musts. This is an extensive process, and it does take some time, but it is put us on parallel with other healthcare providers. What we've learned through the course of the last couple of years is that this work can start now. In fact, most pharmacies are already internally credentialing or going through some review process to ascertain that their pharmacists working under their roof are actually licensed and competent and in good standing. And so that process is in many ways credentialing. And then we do have pharmacists that are submitting their certificates to show credentials in immunization, in tobacco cessation, in anticoagulation or other areas. And in many ways, we're already doing this work. We just need to use the right terminology, put the right policies and procedures in place to demonstrate that we are credentialing and are privileging, and that will expedite the process of contracting with plans. The other component on an individual level is to understand what is required for these applications and try to start collecting that information so that you can fill out a practitioner application and be ready to go. So don't wait, prepare now, and it will help when the door opens. This is obviously a new process and one that's evolving in understanding for our members. So we've developed a contracting, credentialing, privileging resource center on our website. And so inclusive in that are some tools to help with understanding these credentialing processes, knowing which plans are active in the state of Washington and that need to comply with our rules, and how to contact the right section within their provider network enrollment space. It should be noted that if you go to the pharmacist section, you will likely not find anything other than PBM contracts. So you're going into the health plan provider network component, and so we needed to direct them to the right space. We also have provided some sample provider contracts for the review and webinars to help them understand the process in more detail. Once you're in the provider networks, it's time to start providing that care and submitting claims. But it can be a little different than submitting a pharmacy claim. So are you ready to walk through the reimbursement maze? This next section outlines the work of our billing, coding, and documentation work group, whose task was to understand how other providers bill medical claims and how they compared to the pharmacy billing process, and ultimately how to successfully submit a medical claim to a health plan. The medical billing process is different from the pharmacy billing process in a number of ways. There's different codes that are utilized, there's different terminology utilized, and there's different standards for electronic transmission. And so we needed to get a better understanding of how what we understood in the pharmacy space differs from what we will need to understand in the medical billing processes. One of the first things we need to do is understand all the terms, and this is just a subset of the billing and coding terms, but the American Medical Association CPT codes and ICD-10 codes are somewhat familiar to some pharmacists, but we needed to know how and when to use them appropriately. In addition, we have the HCPC codes, or the Healthcare Common Procedure Coding System, and then we also needed to know the medical billing standards. And what we've identified is that most of the commercial plans work through CMS medical billing standards, and so that helps to streamline our efforts for understanding the standards that will be applied to us, and that could parlay into nice transition if and when our Medicare Part B legislation is passed. In addition, there's also documentation codes like the SNOMED CT codes, and when are we supposed to use those, or how are we supposed to use those? They're not billing codes, they're actually documentation codes, so how do those play a role in what we're doing? As we prepare to document, code, and bill for medical services, it is really important that we understand the following areas. We have to completely understand the medical billing and coding systems that are utilized to bill for medical services, as well as the importance of thorough documentation processes to not only justify the medical billing and coding that's been submitted, but also to communicate the care that's been provided by a pharmacist to the rest of the healthcare team. Incident 2 rule needs to be revisited. While it's been a core part of pharmacist billing to date in many settings, there are supervision requirements, the general, direct, and personal supervision requirements, as well as some associated risks to pharmacy practice that we need to have a better understanding of, as we may, in some cases, need to use Incident 2, and other times may be billing directly through other codes. In order to appropriately bill for the services, we need to have an understanding of consultation codes such as evaluation and management codes. These codes actually have been fundamental to date in billing for pharmacist services, as they very much uh, grasp what a pharmacist can do in medication therapy management, as well as chronic disease state management, patient care moments. They can be billed a couple of different ways, and it's important that we understand how to appropriately document and select the method. The time-based method, which is pretty direct and straightforward in time-based segments, needs to be justifiable to the amount of time spent through documentation. And then there's the complexity-based coding uh, and billing method, which can be justified by three main components, either by the history, the patient's history, the components of their physical examination, and or components of medical decision making. And these can be fairly complex upon the onset, but once understood, I think there will be a core component of the billable moments provided by pharmacists. And of course, we have to prepare for the eventual audit. So understanding what those audits look like, the laws and regulations we need to comply with. And then one of the major differences between medical billing and pharmacy billing is the collection of uh, payment by a pharmacist or provider after the care has been provided and the bill has been submitted, which is different from billing a pharmacy claim, where much of that happens typically before the patient receives the medication and the care. Now that we've discussed some of the essential elements for medical billing, let's talk about the process. The process includes key steps such as the pre-visit, then the patient care, the submission of that medical claim to the insurance company, and then some work that's done post claim transmission to ensure the accuracy and success of that insurance claim. And then after a insurance payment's received, then there's some reconciliation and a need to reach out to the patient for payment for the care that they've received. The pre-visit contains some of the standard pharmacy claims process components, such as collecting patient demographics, their insurance information, their medical history, and the like. But then there's an additional step. We need to verify that that patient's insurance is accurate, is active, and that they're eligible, and then what services potentially what their coverage consists of. And then if there are copays that would be required for visits, we need to collect those at that time. And then there are a number of additional documents such as medical release forms, some financial documents and privacy authorizations, and potentially even prior authorization components that need to be addressed during a pre-visit. Once we've done all the pre-visit work, filling out all the forms and clarifying that the patient has eligibility through their insurance, then it's time to assess the patient and provide patient care. The emphasis during the patient care process that's a little bit more refined in the medical billing side is that we need to focus on documentation. We need to ensure that the appropriate documentation is in the medical record that can justify the code and severity of the claim that's been filed and submitted. In addition to that, we need to make sure that that documentation is clear on what we've provided that patient, and we need to transmit the necessary documentation to all the other providers that are providing care to this patient so that that care is entered into the patient electronic medical record and accessible to all other providers. Once the care has been provided and the visit has been appropriately documented and the information has been shared with the other healthcare providers, it's time to submit a medical claim. So it's important now that we re-verify that the patient, provider, and insurance information is accurate, and then we have to select the right codes, diagnosis codes and procedure codes, so the ICD-10s and the CPT codes based off of that documentation that's in the medical record. And then we need to submit that claim through the appropriate electronic processes to be received by the health plan. Once we've submitted the medical claim, there's a little bit of babysitting that needs to happen in this process. We need to make sure we're checking back on the progress of that claim to see if there has been any correspondence by the insurance company as by way of denial or request for additional information or a prior authorization need and the like. And so then when we resolve those issues and resubmit it, that process can be a couple of months. And so it's important that we have a process in place that allows for a staff member to keep up with the status of those claims. Once a claim has been approved and paid, then we need to verify that it matches what we submitted and or any contractual agreement in place, see if we've got paid appropriately and address any issues there. And then we need to reconcile that with the coinsurance or co-pay payments that the patient paid up front and then look to see what the additional patient responsibility might be. And then this is something new for pharmacists because in most PBM contracts, pharmacists are not able to go back to the patient to get any difference in what the insurance paid versus what they require for payment. But in many states, there's the allowance for balance billing, which would allow for a healthcare provider, a pharmacist in this case, to then go back to the patients and bill the patient for any part of the service that was not covered appropriately by the insurance, and that requires a new process to follow up with the patients called revenue cycle management. Well, I just summarized some of the essential elements for understanding medical billing and some of the key steps. It's a much more intensive process, and to help our members understand it, we've created on-demand training components, CE courses, 10 of them that outline the processes and specifics on billing, coding, and documentation and compliance. We've also hosted a couple live medical billing workshops for pharmacists and technicians and other pharmacy professionals that might be in charge of doing this at the pharmacy level. And we're in the process of finalizing our guidebook that we've worked with the American Medical Association on as a reference for medical billing, coding, and documentation. In addition, we are putting together more specific on-demand training online CEs that will be focused on specific disease states or clinical focuses as well as case studies. And those will be an effort to tie clinical interventions to the billable moments in a more comprehensive and targeted way. The Technology and Communications Work Group had a heavy task as well, and this one really looked at what's necessary to submit these claims, how does that differ from how we communicate with PBMs through our pharmacy management systems, and how do we bridge that gap. First thing we need to do was demystify the differences between a pharmacy claim and a medical claim. And this was a big task and one that we spent quite a bit of time on because we wanted to make sure it was clear. Start with what you know and then move from there. So the pharmacy billing cycle, and this is a little small, but you can see that there's a collection and verification component on the left-hand side, which is your order entry component. It gets into a claim submission section where that claim is submitted through a vendor to a PBM largely, and then there's the adjudication of that claim and whether it's going to be rejected or accepted, and the payment component that elicits from that, and then that triggers the filling of the medication, and then the patient care component of patient counseling and discussion education happens at the very end of the process. This is all very familiar to most pharmacists, so I'm not going to get into a lot of detail here, but this is just to outline the different components that happen within a pharmacy billing documentation process that we might not be considering as documentation. We just have done it for so long. But as we get into the medical billing, we wanted to be able to parallel those. So the medical billing cycle it has the same components, the collection and verification, the claim submission, the payment, and the patient care. However, the patient care component is much earlier in the process in a medical billing cycle. And so that's of note for a number of reasons. Because the patient care happens before the claim's submitted, that changes a lot of what we need to do on the back end. So in addition to that, we've identified 5 gaps, and you can see those at the bottom of the slide. Those are the key areas where the medical billing cycle and the pharmacy billing cycle differ. Well, we've already talked a little bit about the medical billing documentation process. We're looking at it again from a different vantage point. This is the technology purview. And so we broke it down into those 4 components, but there are different technology gaps and concerns that we would need to address in how we transmit this information. So if we look at the collection and verification standpoint, while we're collecting a patient's history, medication history, and demographics, we'll need to have a place to be able to store those. And in the collection verification stage, we also have a need to verify insurance information real time, check their eligibility, what copays or coinsurance are necessary, deductibles. In addition, since the system for billing a patient is a little bit different in medical billing, we will need to take into account some revenue cycle management concerns. We will need to have an idea of what their out-of-pocket estimate is, what the contact information for that patient is upon reaching out to them later in the process, and have to collect deductibles and copays and potentially credit card and other documentation. And so then where is that stuff stored and how is it retrievable later in the process? From a patient care standpoint, we need a place to be able to store key history, examination, and medical decision-making information like an electronic medical record. While much of this process parallels the pharmacist patient care process by JCPP, we do have a need to now store that. Do we have the ability in our current system to store that, or are we going to have to find a new solution? In the claim submission process, we need to be able to send this information to a different source, a different adjudicator. We're no longer going through a PBM, we're going through the health plan, so we have to know the new standards for these electronic forms, how to send those, understand the differences in those forms, and then be able to check up on our claims after they've been submitted, and then have a way to review what has been paid with what the contracted rate was, reconcile those, and then eventually do some revenue cycle management to collect additional payment from the patient. All right, now let's go back and look at those gaps that were identified. Gap number 1 would happen in the collection and verification side, and that's in the patient management component, where you now need to be able to have a way to determine insurance eligibility, schedule appointments, collect patient information. How are you going to document and store all that stuff? And typically that's done by a practice management company or a vendor or software solution. And actually it can also, in some revenue cycle management systems, have now evolved to offer that within. So you might be able to have one solution that helps in the practice management side of the upfront and the revenue cycle management on the back end. But the solution really is, how do we ensure with practice management software or potentially revenue cycle management, what are the regulatory compliance restrictions and HIPAA components, any insurance information needs to be collected, claims processing and tracking, charge capture and posting, reimbursement management, the patient billing, and the like. Those are all solutions that could come from a practice management software. During the patient care component, the second gap has been identified, and that's clinical documentation. How do we document the right information and make sure that it's accessible upon audit or justification, or in trying to identify what appropriate codes should be billed? And typically the solution with regard to this is an electronic health record or an EHR, some system that's designated as ONC certified health information technology. The ONC is the National Coordinator for Health Information Technology, and they certify these groups. So you want to make sure that they are they have deemed this electronic medical record as certified. And within that, you can within that solution, you can maintain a medical record. You can have internal clinical notes and documents. You can also bring in external notes and documents, any lab values or imaging documents that are necessary. There's e-prescribing components. There's staff workflow components. There's meaningful use certificate components, and as well as patient portal in a lot of these solutions. Gap number 3 came in the claim submission process, and that's the coding and claim submission. So really making sure that we understand the industry standards to code and submit claims. And there's a couple different solutions that can help with regard to that, the clearinghouses and the billing services. The billing services help with coding compliance, making sure that the right codes are being selected. The clearinghouse actually looks at the claims compliance, overall claim, does it all meet the muster, and then it can transmit that to payers securely through the appropriate standards. Gap number 4 and gap number 5 both fell into the payment. So let's look at gap number 4 first. This is a different adjudicator. We're dealing with a payer that's adjudicator, not the PBM that's contracted with the insurance payer. So it's going to a different group. So how do we know who to send it to? How do you understand what is the necessary standards and what format they need to be sent? And so a solution here is largely the clearinghouse. They're the ones that can transmit this to a payer, and they typically are the ones that will double check and make sure that this is a high likelihood of being a successful claim, and work to make sure that your claims get processed. Gap number 5 is in the payment collection, and that's tough because now the pharmacy billing mechanism and claim submission had all of that up front for the most part before any product went out the door. Well, now that the care is provided so much earlier before the claim submission, that requires you to go back to the patient to figure out what the insurance covered and what it didn't. And the good part is that unlike pharmacy contracts, a lot of medical contracts allow you to have some balanced billing, meaning you can charge the patient what the insurance didn't cover, with some caveats obviously included in that, but that allows for pharmacists to deal in much the same way physicians and nurses and the like have done it. Now those can vary state to state, and some state laws prohibit that. And I know that there's a focus on making sure patients know what they're getting into up front. But at current time, that could be a process that pharmacists could do, and so you need some help with that. And that's where the revenue cycle management components come in. And as stated before, some of the practice management software have built in some of these services into their offering as well. But essentially, what you're looking at is the charge capture and posting, and the reimbursement management, patient billing and collection, and those aspects to make sure that you've been appropriately paid for the care you've provided. The electronic transmission standards are also new terminology for us in this space. ANSI X12 is the standard for most electronic communication, and while your partners or your software solutions will be up to standard, it may be important for you to understand what some of these standard forms are while you're shopping for your appropriate solution. The ANSI X12 270 form, for example, is one that you would submit early on in the process during the pre-visit to identify insurance eligibility. So you would send that to a healthcare plan to verify that a patient's covered and what that policy coverage is. And then they would respond with the 271. If you are needing to request a referral or authorization, you would use the NCX 12278 as the industry standard. And that's used to obtain prior authorization from plans for services or to refer an individual to another provider. Some payers have different proprietary transaction software for this, but for the most part, the industry standard is 278. The most common form sent is the X12837, and that's actually your medical claim form. That's what a provider sends to a health insurance company with the information of the claim. It will include a patient's description, the conditions for the treatment provided, what services were provided, and the treatment costs. And then the insurance plan will use an 835 remittance to detail if it's been paid, what the price has been paid, or if it's been reduced or denied. It will also include information about deductibles, coinsurance, and copay. So this is a really important form. In fact, this is referred to in the paper format as the CMS 1500 form, which was previously called the HCFA 1500 form, and some pharmacists have used those to submit various services or devices over the years. This is the electronic format of that. And then once that 837 is submitted, we talked about the babysitting of the forms, like where is it in the process once you've submitted it, how can you get your claim status? And so the X12276 is a healthcare claim status inquiry, and that you will submit that form to check and see where it is in the process, and subsequently the health insurer will remit back to you a 277 response. Which will let you know where it is in the process, whether it's been rejected, denied, or approved, and the like. After reviewing the technology gaps and the new terminology for electronic transmission standards, we wanted to make sure that we looked at what new vendor relationships or solutions are out there. And when we discussed the gaps, we identified the need for to fill those gaps with electronic health record systems and practice management systems and clearinghouses or billing services and revenue cycle management systems. And those exist. They are out there. They largely have worked with other provider groups. We've reached out to them to educate them on pharmacists providing in this space and to see if they have the capacity to integrate with pharmacy management systems in a reasonable way. Certainly, those folks working in clinics and hospitals already have billing mechanisms in place, and they would just need to insert themselves into those. But in the community setting, they really don't exist. And so there may be some opportunity to bill through relationships you have for billing medical devices, but there certainly will need to be an additional component of an electronic health record to collect and store the appropriate patient-specific data. A bridge to the pharmacy management system would be ideal so that there's not redundancy and rework. Practice management systems for scheduling and billing and collection, or revenue cycle management systems to help with the collection are fundamental. And the clearinghouses and the billing services to help to maximize the review prior to submission of the claim to make sure that it has a high likelihood of being a successful claim and not having any delays in payment. There are integrated systems out there that have the HR and practice management system together, and there are some reasonably priced solutions out there that are being developed that could integrate nicely with the pharmacy software. This is clearly an area of development, one that is in flux and very dynamic, but we are seeing the software systems have interest in and try to create solutions to ease the pharmacists' transition into this space. We do have some pharmacists that are working with multiple groups right now to build their care, and others that are looking at what their solutions might be. Our outcomes and research work group is really just getting started, and we truly envision this as the most fundamental and long-standing of our work groups. The first three are helping to change the system or understand existing systems for implementation. But this work group is going to be long served in showing and demonstrating the value of pharmacists to different stakeholders, specifically focusing on showing and measuring and reporting quality metrics that demonstrate the value to health plans. The goals of this work group are to prove the need to have pharmacists in the provider networks, and that's a demonstration that largely will require us to equate the services we provide to value for the health plan. So how do we move the health plan's bar by improving the metrics they're graded on and align those values to metrics? But we'll also be looking at other areas that help pharmacists to improve their business models, to provide this care, and other areas that are not so tied to fee-for-service, such as bundled payments within ACOs and the like. So there's a lot of ongoing planning of what this looks like. While we've been focused largely on implementation at the beginning, we truly believe this work is extremely valuable moving forward. At the beginning of this process, one of our key goals was to not have what happens in the Pacific Northwest exist in a bubble, and that we really wanted to focus on how can we share the lessons learned, the successes, the tools throughout the country to help at the federal level as well as at the state level. And so we had created a center within the Washington State Pharmacy Association called CHOICE, the Collaborative Healthcare Outcome Improvement Center. And we want this to be able to serve as a vehicle to share some of the information and help the effort nationwide. CHOICE was developed as a home for our implementation tools and resources, as well as our work on data analytics, outcomes measurement, and performance metrics, with a collaborative approach on research work with universities and other states. We specifically did not include Washington State or pharmacy in the name of the center because we want the center to have the focus of collaborative outcome improvement and be a vehicle for us to share information with insurers, self-insured employers, and other research bodies as we want to demonstrate the value of inclusion of pharmacists within the healthcare team to the entire healthcare system. And so while this is a very long process and one that is compounded by the amount of work that pharmacists already have on their plate, I'm very happy to say that the roadmap actually works. We've had pharmacists that work in hospitals, clinics, and community pharmacies all successfully get into networks, provide care, and bill for those medical claims and be paid by multiple different payers. Most of the claims that they're billing are the evaluation and management consultation codes, and they have billed those not only in the incident 2 billing, which is a level 1, but all the way up to a level 5, which is the highest complexity. And those level 5 claims are often audited, and they've been validated as being accurate claims. So not only are we billing claims, but we're billing high-level, high-complexity claims, and they're being approved as valid. It's exciting. It's a great deal of work to get into these networks, but it is yielding results that are very promising. It's early in the process. We certainly still have more of our pharmacists in the implementation phase, trying to enroll in these networks and figure out how they're going to bill these claims, than we do actually billing claims. But the ones that have billed claims have yielded good results. In 2016, we worked with one of our payers to share with us some of their initial findings, and they had paid out a little over 2,000 claims and had paid out over $200,000 to pharmacists providing those services. And that's just one of the plans, and it was when there was only a limited number of pharmacists in their network. So it is worth the time to do it. It's exciting that we're getting those results, and we have great optimism for the road ahead. So now is it finally time to celebrate? I mean, pharmacists are getting paid for services in all these different settings, in community settings, in hospital settings, in clinic settings. Well, yeah, we are excited about that. Absolutely. We wanted to make sure this wasn't just a victory on paper, that we were able to capitalize on getting pharmacists into this new space, navigating through the enrollment into networks and figuring out how to build these medical claims. So it is very promising. But there's still more work to be done. As I had stated already, there are still more pharmacists in the implementation phase than in the billing phase, and so we've got some work to do there. But we are excited about the successes and are very interested in catapulting those into greater uh, enrollment and in those networks and more billable moments. In our mind, it's not success until it's the norm. So we've still got more work to do. We've reevaluated our next level of work, and we're looking at ways that we can continue to assist in the education of health plans to understand the billable moments, to address any barriers that billing pharmacists are having with the health plans or enrolling pharmacists are having getting into the networks. We also know that there's a greater lift to implementation in the community settings. Well, hospital pharmacists and clinic pharmacists already have billing systems in place for their other providers. That typically hasn't occurred in the community setting. So we're focusing on billing solutions that work in the community setting and addressing any barriers to implementation that are arising. At the end of the day, I think it's important, and we're working on establishing a viable business model for community pharmacies that have contracted pharmacists providing care under their system. There's an overhead, high cost of implementation, getting these pieces together, and there are delays in getting revenue with medical billing that need to be investigated and addressed, and workflow and staffing changes that might stand in the way. So we want to see if we can put together a business model to demonstrate for our community pharmacists or independent pharmacists that this is worth the effort, and at the end of the day, despite maybe some past experiences with MTM and other things, that this is different, and this is a way that they potentially could change their revenue stream, increase their value to the healthcare system, and their ability to care for patients that's unique and different from the dispensing of medications. When we started this process, we had to create a new path through the forest, and that path is getting wider and wider as more and more folks go through it. But we want to continue to evolve this into a paved road and eventually a superhighway that stretches from coast to coast. This is really exciting for our profession to be able to be perceived as providers and to be able to bill for our services the same way other healthcare providers are billing. It's the way we've been trained, and it's what we deserve to provide to the system. We've worked hard to gain the knowledge and expertise that for so many years has been stifled by this lack of recognition. So we want to take the opportunity before us and turn that into success. So we are committed to making sure that this not only works in Washington State, but also works throughout the country. In order to capitalize on our opportunity, we have to adapt, and that's a big challenge, especially in the community setting where we've largely had a business model that's surrounded around dispensing of medications, and there's a bigger adoption and implementation necessary. But Nolan Ryan, a Hall of Fame baseball player and former CEO of the Texas Rangers, summed it up really nicely when he said, enjoying success requires the ability to adapt. Only by being open to change will you have a true opportunity to get the most from your talent. And that's where we are sitting. We have the talent. We have the training. We've had that training for a long time, but we've been suppressed by a system that didn't recognize that for its true value. And by opening up this door to the medical provider world, what we have now is an opportunity to capitalize, but we have to make some changes, and those are hard, and we recognize that there's risk involved with that, and so we're working hard to support that challenge of adapting and moving folks forward to an area where we can truly capitalize on our talent. To help with the challenge of change, WSPA and Choice are working to share resources, and we've created Pharmacists as Providers implementation page on our website with checklists and resource centers to help facilitate the knowledge necessary to make the transitions and start getting recognized as providers. Here's some references that I referred to earlier on: the Credentialing and Privileging of Pharmacists from the Council on Credentialing and Pharmacy, the advisory work group materials that frequently asked questions document the health plan policy directives, those key tools that will help in the implementation or the recognition of by the health plan of how pharmacists could be inserted into their networks. And then on the Pharmacy Association side, our Getting Started checklist and our Contracting and Credentialing and Billing for Patient Care Services resource centers. Again, a special thank you to the Community Pharmacy Foundation. This work it was laborious and it took a lot of time, but we would not have had the ability to do it without the grant support and the patience that the foundation offered us as we went down this road. So with that, I'll close up. On my email and our website are on this slide. If you have any questions about the content, please don't hesitate to contact me, and we'll be glad to work with you to clarify any questions or point you in the right direction for solutions. Thank you so much.